to check in.
Okay, I added it.
I was like, is there anyone down? There's no one down in the lobby, so I don't know if everyone's.
Join on. You're just gonna join on here at the time that we're.
I'll just start.
I'm just starting.
We'll see if I can pass this text.
Oh, goodness. Oh, Brooks. That's what she would be.
Very short. There's a whole lineup on the side.
I just asked Barb at the lobby, and there's no one down in the lobby. And I was like,
Me too. Kelly's.
Is Lisa right there?
Just us.
I don't know.
It's okay. Nice. I just did this.
Yeah, no, it's gonna take all day. It's probably gonna push all kinds of things. Yeah. Updates that I can't get because it's not on the internet.
It's beautiful. Yeah, she found us some too, like. That's the only reason I put it in call, because I like to see covered bridges.
So I try to make sure I get places early. So even though you have to do presentations, you get some joy out of it.
To see what it's like on the outside.
Yeah.
The cover bridges.
Yeah, I'm trying to get on too.
Anyone else have any?
Okay.
I
I actually got it today, but last week, no. So it's a real toss up. Oh, isn't? Wasn't it? You really actually set it up. No, it's being up to do that. I think that might have.
can probably share screen because I have internet access.
If anyone's in the lobby.
Is Kelly the vice chair?
Yeah.
She's. See the games.
So it's between ball pitch and snowball.
We're just doing one final check in the lobby to see if anyone's arrived, and if not, we'll get started. Lisa, Britt, are you on? I'm not seeing Kelly, but
Yeah, I know it's the mic on.
it looks like the mic's on.
Can you hear us? Yeah.
We can hear you.
Oh,
Okay.
okay, thank you.
We can hear you.
There's good people in the lobby. I'm like scanning them. I'm assuming this one is the first.
Yeah, maybe Kelly. 'Cause she's-
There's just a few people coming up in the lobby, so give it another minute or two, and then we'll get going.
I tried.
Yeah, I rebooted it and got on. Second time was the charm.
Maybe it's a second time.
Yeah, yeah.
That worked. Oh, no, no internet connection.
Do you want me to check your connection? And you don't have to do it.
But I think it's all connected. Oh, there's a blue one over there. That's the Ethernet.
Yeah, and then there's a lot
It
of.
says I can't connect to any of these things. So I just tried to do guest login.
I also don't mind sharing.
Yeah.
Cause
I
I'm,
don't know if I'll be able to share any.
Yeah, we might-
I won't share any information.
I can share mine, and then
Do you want me to email you my PowerPoint?
I can share 'em.
I'm just gonna shut down.
That's what you need. Do you have an Ethernet connection? A cord on the inside?
Morning.
Morning.
Moved away from the lobby, sorry.
No,
Yeah, exactly.
there's good news. Gave a daughter for the healthy baby girl yesterday.
Yay, oh, that's
Yeah.
nice.
Yep, great.
Yeah, like almost like, exactly.
Sir?
Yeah.
All right.
It's like nice.
Good morning, everybody. We can dispense with introductions and announcements because I don't think there's anybody new here this morning, am I right? Just the regulars, okay. Has everybody had an opportunity to look at the June and July minutes? Seeing heads nodding, excellent. Do we have a motion to approve June and July? Can I do 2 months in one motion?
No, I wouldn't do that because people might have, I know I have comments about the July minutes.
Okay, Karen,
Thank you.
do I have a motion on the June minutes?
Mike Auerbach, so moved.
Thank you, Mike. Do we have a second?
I'll second.
Thank you, Karen. All in favor? Aye.
I,
Excellent. Thank you. Do I have a motion for July?
So moved.
Thank you, Kelly. Do we have a second?
Second.
Thank you. And Karen, do I understand you have discussion?
Yes, thank you. Just a few things. One is on page 1, the future agenda item request. The agenda item that I had requested regarding Mead was actually broader than what's here. So it also encompassed wanting the department's response to an article published in the New Hampshire Bulletin about an allegation that the department had improperly overcharged and kept funds from Mead participants. I think I emailed you and some others about that in the beginning of July. And then, oh, I guess I have my hand up. I didn't mean to. And then, look, so, and then this second part thing I have is on page 2. I think that I guess I'm a little bit confused about what these minutes are. There's also something attributed to me about asking, which did happen when I asked about a contact person at the department to reach out to, and then it includes follow-up that occurred after the meeting. So if I'm correct in assuming that the minutes just reflect what occurred during the meeting, then I think what occurred during the meeting was that I was told, and this did happen, so thank you, that there would be follow-up with me afterwards with a contact. And then, all right, this is a picky little thing. On page 4, the very bottom, I think that this was a word choice that was incorrect there's a bolded section about planning for new rules on MCAC and BAC. And the second bullet point, the last sentence talks about the BAC is meant to preempt the MAC. I don't think that's really I'm not sure what was said, but I'm sure that wasn't what was meant. Yeah. So I'm sure there could be a correction there from the department. Again, a picky little thing on page 5. 1, 2, 3, 4. The fourth bullet point, I think that the second line is meant to say institutions, just with an S on it, not institutional. Like I said, that's super picky. And last, also super picky, is on that same page, the 5th bullet, 4th line from the top, it has my name spelled wrong. It's ERG. Thank you. That's all I got.
Further discussion?
Carolyn's hand is up.
Karen, was there a motion for amendment there? And if there is, I would second it.
I don't think there's
a motion has been made yet. That was part of discussion.
So you
I
don't
think
have
there
to
was a motion
second it,
I
you
think
can
we
make
agreed
the
to
motion.
discuss. I don't know that there was a motion to amend. I thought we were discussing what might need to be amended.
That's correct.
Okay. I would like, was I recognized, Lisa? Did I hear you say my name or?
Kelly did.
Oh, Kelly. Okay, thank you, Kelly. I am not listed as excused from the July 8th meeting. And I did email, I believe, the appropriate parties. So I would like to be added as excused. So I would like to move for that correction. And then in the review and approval of the June minutes, it says there was the decision was made to wait to the July meeting to vote on the June minutes. Did you mean August? Because these minutes are of the July meeting. And if you did, I would move to correct June to August. I'm sorry, July to August. And I'm on page 1, review and approval of June minutes.
How you doing, Kristen? You got all that?
So procedurally, where we
I-
already approved the June,
No, I'm on July, page 1, review and approval.
okay,
Yep.
got you, okay, okay.
June minutes. Didn't we just vote on the June minutes, Lisa?
Yes, we did.
All right. So if that makes sense to
July's
everybody
June
else and just not me, you can leave. You can leave that.
So I also took some notes, if that would be helpful to back you up in reconciling it.
Yeah.
But it does make sense to me. She's just mentioning that July makes a reference to reviewing June and July when we're really reviewing it in August.
And that's
Sure.
the request I'm asking for, Kelly, the amendment.
Yeah, I hear
need
you.
that we amend it to say wait until the August meeting. But I wasn't there. I'm just recommending the correction. And I do move that the minutes be amended to include me as excused. And if someone would second that, I would appreciate it.
I'll second all the amendments.
We have a pending motion on the table, so I think you need to withdraw your motion to approve July so that we can entertain the motion to amend.
Okay, withdraw.
Thank you. So Karen and Carolyn, you both have recommended amendments. I will move to amend July as the two of you have outlined. Kelly has good notes, mine are mediocre. We will support Kristen in having a better version available for next month. I just feel like that's a lot for us to try to do on the fly. I don't mean to underestimate you, Kristen.
No.
Okay.
Okay, so
Karen,
we'll just, so do you mean we'll just review them next month? Is that what you're suggesting? Or do we?
We're
or-
entertaining a motion to amend, as you and
Okay.
Carolyn have requested.
Got it.
And
So
did anybody
I'll second it. Is your
Excellent.
motion.
Thank you.
Okay, thanks.
Any discussion of the motion to amend? Hearing none, those in favor? Aye.
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 Those opposed?
Aye.
Hearing none, we will have a new version to look at next week, or next month, hopefully with those changes. Okay. Okay, so the next item on the agenda is looking for future agenda items. Karen, I know you've already flagged something that you were hoping would be on today's agenda. I'm not sure, Dave, if you had a chance to be briefed on this at all.
Yeah, there are a couple things I can, a couple of pieces of information on the meat question that Karen brought up from a prior agenda item. So the department was aware that there was an issue with overcharging meat balances and in some cases undercharging them. And this occurred during a transition from New Hampshire Hospital to when it used to run the account balances for meat, and it transitioned to the department in around 2018. So the Bureau of Program Integrity has run audits and account reconciliations, and they've done over 3,000 as of now. There were 478 members who were identified and refunded. There were 40 balances that were sent to abandoned property because the person is deceased or we were unable to locate them. There was 1,970 that had 0 balances. So no action was taken by the department for those cases. And then there were 416 cases where balances were owed to the department, but we didn't pursue collecting those balances because either they were carried over from the New Hampshire hospital database and we couldn't verify those amounts owed. The person is deceased. The person had never made a payment and we weren't able to find any contact information, or the balance was under $10. And since February, for the balances or accounts that had they owed money to the department, there's been around $1,300 collected. Yep.
This is Kelly. I'm asking a question. I thought when Karen asked her question in reference to the article, she said it was related to me. That's correct?
This is, yep.
Okay.
And for the MEAD program too, so the premiums were suspended for the PHE, and then there was legislation in 2022 to essentially make permanent that we would no longer be charging premiums for MEAD. So we're currently not charging premiums for MEAD, and absent a state legislative change from that, we won't be charging premiums for MEAD in the future. So this is a historical account reconciliation. Yep.
So everyone has been refunded who you could refund. Is that what you're saying?
Yep.
Okay, thank you.
Yep.
Carolyn, do you have an additional question?
You, Lisa, I had requested an agenda item many months ago in regard to state plan case management. Last month's meeting said the department will follow up with me offline. No one has done that, and I do think it is an important agenda item for the full committee. I will just make that comment.
Are there additional agenda items for future meetings? Hearing none at this time. Can we just make sure somebody follows up
Yep.
with Carolyn on the state plan CFI stuff? Okay. So Carolyn, Dave says somebody will get in touch with you. Thank you for your patience.
Okay, thank you.
Okay. Shall we move on to justice involved youth?
Yes. So the justice involved youth agenda item, it's a new requirement from federal legislation under the Consolidated Appropriations Act, and it's a nationwide requirement that requires states to provide a limited scope of pre-release services to youth that are leaving an incarcerated setting, and then some post-release services as well. So I've asked Jordan McCormick to give us a little bit of a briefing on it. So she's going to share some slides.
Okay, so as Dave said, the section 5121 of the Consolidated Appropriations Act requires state Medicaid and CHIP programs to have a plan in place, and in accordance with such plan, provide for targeted case management, screening, and diagnostic services for an eligible juvenile who is within 30 days of their scheduled release date from a public institution following their adjudication. Compliance requirements right now, our requirement date is 1/1/25. What the state is required to do is to submit a state plan amendment with an effective date no later than 1/1/25, which really gives the state till the end of the quarter, so 3/31/25 to submit that, and to have an internal operational plan in place by 1/1/25. CMS isn't explicitly requiring us to submit that operational plan, but it must be available if they reach out and ask for it. Another kind of important component is ensuring that the processes and procedures developed by the state to support implementation do not effectuate a delay of an individual's release or lead to increased involvement in the juvenile or adult justice systems. So the members that are included as eligible juveniles includes anyone 30 days pre-release. If the release date changes, then the juvenile will be resuspended, their eligibility will be resuspended until they re-enter a 3-day pre-release period. An eligible juvenile is defined as an individual who is under 21 years of age, who was determined eligible for any Medicaid eligibility group, or an individual determined eligible for the mandatory eligibility group for former foster care children immediately before becoming an inmate of a public institution or while an inmate of a public institution. So former foster care can be up to age 26, 21 through 26. We need to identify a mechanism to identify former foster care members. We already do that in our application process. And CMS believes up to 50% of youth referred to the juvenile justice system are also involved with the foster care system. So up to 50% of that 21 to 26 age group may be former foster care. For New Hampshire, this will include the New Youth Services Center, state prisons, county jails, and other facilities. We know that for the state facilities, it's about 137 youth. We don't exactly know based on the former foster care identifier, but just kind of applying that 50% assumption. That's what we're expecting on the state side. Of course, we have to account for counties and Sununu and other treatment centers. And I have some of the other facilities listed out on the slide as well.
May I just double click on that for a second? So that universe of roughly 137 youth, they are already Medicaid eligible, or this is any kind of?
That would be anyone in that age group.
Okay, thank you.
Sure. So we have two options. Upon incarceration, we can either suspend eligibility or benefits. If we suspend eligibility, it means eligibility is not terminated. An annual renewal would be required, and the juvenile cannot receive any Medicaid coverage. This is before the 30-day period. Or we could suspend benefits, which means eligibility is not terminated. I guess that's true. Eligibility is not terminated. An annual renewal is required, and coverage is limited to inpatient. So I think that's something that we need to work through a little bit more, because as I understand it, we're kind of doing some combination of those two, and so we need to make sure that we're following one of the defined options. States should be conducting pre-release outreach well in advance of that 30-day period. We are, responsible for identifying anyone that has not already been determined eligible for Medicaid prior to the 30-day coverage period. We're going to make eligibility and enrollment support available to all incarcerated youth. Again, we'll have to establish processes and procedures to assist with the application process, do early outreach and consistent outreach to youth, help with the applications. We are allowed to have someone acting responsibly for a minor submit and sign an application. I think this is something else that we really need to talk through as a state, because I think that presents some complications, but it is directed in the CMS guidance. And the goal is to have an application for youth that's not already eligible and submitted no later than 90 days before release.
Jordan, can I ask a question? Sure. I get a little confused by the reference to public institution, because I know that we're talking about a subset of public institution.
Mm-hmm.
And so I just want to make sure that I'm right, that we are talking about a subset of public institution. And because like New Hampshire Hospital is a public institution in accordance to federal definition.
Right.
So if we can just remember that, because, yeah, okay.
I think
Keep some of us honest.
some of this language, unfortunately, came right from the CMS guidance, like
Right.
the use of the word inmate,
Yeah.
which is not necessarily how we would choose
Or
to
use
use that.
Well, and then
Right.
another slide, we
Right.
reference group home.
Yeah,
And so then I get confused again. So it makes me question myself. It's just good to be, I mean, I think you're doing a great job, so thank you. And it's clear to me what we're talking
Yeah.
about,
Yeah.
but the nuances of some of the verbiage that they use
Yeah.
can cause confusion.
And I do have, I'll send out the full deck. I did cut this down a little bit just for time. So we'll send that out, and it does have a page of definitions.
Great, thank you.
Hopefully help, but yeah, as Ann said, we're just going by the terms used in the CMS guide.
And is it fair to assume that the thinking behind pre-release services and post-release services in terms of targeted case management is to prevent readmission to some kind of hardened environment?
Yeah,
I just wanted to say the quiet part out loud, like, why are we doing this?
yeah.
Okay.
And to
Okay.
just ensure, the success of the person re-entering the community and the health and well-being of the individual. Okay. So in terms of the coverage requirement, targeted case management is going to be offered 30 days or provided 30 days pre-release and 30 days post-release. That covers services available under state plan or waiver. So, planning for services to be delivered post-release 30 days in advance. And then we have to plan for the transition potentially to a new case manager, depending on sort of how we decide to deliver the services within the 30-day window pre-release. But ensure kind of a warm handoff, and there are a lot of specifics in the guidance around exactly what that transition should look like, coordinating between a potentially a case manager in the carceral setting and one in the community, sort of coordinating those pre-release and post-release benefits. Services may be delivered in person or via telehealth, and states may choose to rely on carceral healthcare providers for delivery of some or all of the services. Obviously, we can also rely on community providers. All providers, individual providers, including carceral providers, will be furnishing, ordering, referring, and rendering services under these provisions must enroll in Medicaid if they are of a provider type that Medicaid recognizes as eligible.
Looks like we have a question from Mike, if we could just take
Sure.
1 second, Jordan. Mike, do you have a question?
Yes, and actually, I think this slide is answering it. Thank you. I wasn't sure what the definition of those services was. And in particular, when you talk about care coordination, if the care coordination would include dental knowledge, and it looks like they would, so I'm going to withdraw my hand.
And Jordan, just the targeted case management is included in the services in which it's 30 days pre-release or within 1 week post-release, right?
That's just the EPSDT component. So TCM has to be provided starting 30 days pre-release. The EPSDT piece, those services don't necessarily need to be provided.
Okay. I thought that if you couldn't get someone 30 days pre-release, because they might not even be there 30 days, it had to be all the services were in 30 days or 1 week.
Yeah, I think that's just the screening diagnostic. Yeah. And again, the full slide deck has a little bit more detail that might help. I just knew we were kind of working with 10 minutes.
Sorry.
So as far as the EPSDT services, it's really heavy on the screening and diagnostic services. Again, it would include populations that aren't typically covered by EPSDT, so that age group 21 to 26 for former foster care. And as Anne was just pointing out, it's really we need to provide these EPSDT services in the 30 days prior to release, or not later than 1 week, or as soon as practicable after the release from the public institution. So there are some services that realistically we won't be able to provide, while they're still incarcerated. Some examples of those services are listed out, including, dental, medical screenings, behavioral health screenings, immunizations, and we're working on developing sort of a defined code list that will be in the system, right, to reflect the array of services. We can potentially identify screening diagnostic services that the carceral setting is already providing if they meet state standards for those services, and then our requirement for providing the services are covered. So whether the individual comes in day one and is screened for, goes through whatever screenings that they have, those can potentially sort of meet the need that's required here. They wouldn't be able to bill for that, but we would need to redo the screening at the 30-day window. Again, these may be delivered in person or telehealth, and we may rely on personal providers, healthcare providers, but providers will have to enroll.
Am I wrong in thinking that the youth who are being held in county are going to be the hardest ones to get this over the finish line?
Yeah, I think we would probably agree with that at this point, because we already have such a good relationship with the DOC for state facilities.
Is there already a budget prospectus on this? That's one question, and curious what the funding might be, and I'm wondering about the match. What is the federal match on these services?
There's no enhanced federal match, so it would be similar to the way we get federal match now for when services are provided. Most of it.
Yeah, I thought maybe that I heard for systems changes we get 90%.
Yeah.
Yeah.
Yes.
It'll be in here.
That would do.
Yeah, I was asking about services.
Okay. And like budget, and we're trying to figure that out as it's hot off.
Yeah.
So
Yeah.
in CMS style, you have 4 months to implement.
Yeah.
Yay. But we're trying to align with the counties. So we're doing the adult community reentry, which we have been working on for 2 years. It's going live, but we're working with the state prisons first, and then phasing in the counties. And now with this push, it might be easier to align the two together, because we might be able to have a phase approach with this youth reentry as well. And start with states and SYSC and build those relationships with the counties, and that will be trickier even from an information services systems perspective. I think they don't all look the same, as we know. So,
Thank you.
So just
Got a question up there?
Oh.
This question? Can't see who it is, but I can't tell who has the question, but I can see your hand up.
Sorry, this is Joan Fitzgerald from the New Hampshire Dental Hygienists Association. I did see that you are providing screening services, which is the scope of practice of a dental hygienist. However, providers may be enrolled individually as a Medicare provider. So I would like to add that where we need to grow, perhaps, is to establish the dental hygienist as a provider, just like the federal government has done, and so that we can expand these programs for screening and proper referral for diagnostic and services. Perhaps it's a future discussion.
Okay, thank you. So again, just providers providing services under this provision will need to enroll in Medicaid if they're eligible to enroll. They may either be billing individually as a Medicaid provider, or reassign their right to payment to the carceral facility or an agency contracted by the carceral facility to provide Medicaid covered services. So again, I think that's something the state needs to explore a little bit further and sort of map out exactly where we expect the services to be. Who is going to be providing the services? Who is going to be billing for the services? In New Hampshire, obviously, enrollment means credentialing with both the state and the MCOs, enrolling with the state and credentialing with the MCOs. We at least have pharmacy providers already in the process of enrolling for the 1115. And then as far as the delivery system, we are able to either deliver through fee for service or through managed care. I believe we're intending to deliver through managed care. It will require revisions to our state plan and potentially section 1915B waivers. We will need to work this into our managed care contracts and rate development. Yeah, so sorry, this is the definition slide, but like I said, there's a little bit more info included in the full deck that I'll send out after.
Joan, do you have another question? Is your hand still up
Oh,
from
no,
your first?
sorry.
No worries. I have more of an editorial comment. You said that the sort of Venn diagram between youth who've been in the foster care system and who are somewhere in an institution like this is 50%.
Up to 50, yeah, potentially up to 50%.
That's stunning and sad.
Yeah, it's not a New Hampshire statistic, it's a national, but yeah,
Do we know what ours is?
not at this point. I'm sure we will learn a lot more about.
Yeah, okay, thank you.
Yeah, sure.
I have one comment too. Not that it's my concern, but I guess it could be a shared concern. When I see things like this pop up, and of course, the thought in my head is, boy, they just keep it coming, right? They're always asking you to do more.
Further, faster,
But,
more.
but in alignment with that, it's the budget neutrality issues that concern me, as my experience here with all of you has been. We have a budget neutrality expectation on a number of initiatives that we do. And then the feds ask us to stand up a bunch of different programs. And then when we do that, we exceed the budget neutrality. Not that we couldn't have, because we should have anticipated. If we had known we were gonna do projects X, Y, and Z, and we added them into our budget neutrality forecast, then that would be fine. But when we don't anticipate the things that they're doing, and they don't give us the heads up on that, that undermines our ability to achieve and project good budget neutrality, which ultimately can impact our overall Medicaid program and the services we provide to our members. So just sort of throwing it out there for consciousness.
Good point. Other questions before we move on? Seeing none, thank you so much. Keep us posted.
Will do, I'm sure. There'll be many updates.
All right, shall we move on to the 11:15?
Yes.
Okay.
So I think probably as a lot of people know, there was some exciting news in July. We had our 1115 waiver amendment, extension approved by CMS. And so we've got a 5-year extension on the waiver. And new to this waiver is the community reentry piece, which is similar to what is going on with the justice involved youth, but for the adult population that are at a state prison or jail or a county jail. And so I've asked Carolyn to share a little bit more about community reentry. So let me share some slides.
While you're doing that, I'll say congratulations and thank you for the work that you keep doing on this front.
That's just a nice picture of a cover. So, okay, the next one, thanks. So this is just a snapshot of what our 1115 demonstration is currently. It's just getting bigger and bigger as we add things onto it. So it started with the substance use disorder portion of the demonstration back in 2018. We added on as an amendment the SMI, the serious mental illness portion back in 2022. Dentures was something that we were asked to add due to our legislature. We needed to really get it done quickly, and CMS had advised us that adding it to the 1115 demonstration, the dentures, this is for just nursing facilities, was added back in 2023. And now our community reentry, which was approved in July of 2024, is our newest piece of the demonstration. And I will be sending this out. I'm just, in interest of time, I'm kind of consolidating, but that was just to kind of give you a picture of what our 1115 looks like from the beginning till now. Next slide, please. So this is a great slide that demonstrates what our community reentry component is comprised of. The core features of this are for people with substance use disorder or serious mental illness only at this time for this demonstration. So it will cover incarcerated individuals that have the substance use disorder or a serious mental illness 45 days prior to their anticipated release date from the New Hampshire prison system. The services that will be covered are very limited, and they're including MCO enrollment, enhanced care coordination, initial pre-release visits with community-based providers, pre-release pre-release re-entry care coordination meetings, including community-based providers, peer support, and a 30-day prescription drug supply provided upon release. Now, the 30-day prescription drug supply will be supplied by the DOC pharmacy, which they are, as of a week and a half ago, applied to be a Medicaid enrolled provider, as none of them have ever dealt with Medicaid before. This is brand new for them, but we've really tried to help it sit with them and do the application with them, so it would be a little easier on them, and everything so far so good, went smoothly. So the objectives of this demonstration are to increase coverage continuity, improve access to services for people being released from incarceration, reduce morbidity and mortality, and a lower risk of relapse and recidivism. That's a huge, huge one, goal of our demonstration. So the next slide. We are actually also anticipating this to begin on January 1 of 2025. We're taking a little bit more of a step to be in line with the children's piece of it. So our system changes and things like that, we're hoping to frame around adults and children. Children are 30 days prior to release and adults are 45, but it's still a lot of the same system discussions we need to have. The goals, as I said in the last, this is more of a detailed list of the goals that we have: increase coverage, improve access to services, improve coordination and communication between the correctional systems, Medicaid systems, managed care plans, and community-based providers, increase additional investments in healthcare and related services, improve connections between correctional facilities and community services upon release, reduce all-cause deaths, reduce the number of emergency department visits, and provide interventions for certain behavioral health conditions. So that's really a lot of our goals that we're going to be creating our evaluation design and things like that around. Those are a lot of goals, but we're hoping to be able to succeed at this. We know we will. So next slide, please. Here's the slide that everybody likes, some data. It's a bit outdated and I've asked them for more current data, but this is what we actually use for our budget neutrality calculations. There were 991 individuals incarcerated as of July 2022. Of those, 327 will be eligible for the demonstration as assumed by Department of Corrections. All these numbers came from Corrections. And 426 with serious mental illness. I put mental health because that's what Department of Corrections use as a term, but it's serious mental illness. So 85% of those with substance use disorder will be are released per year, and the participation of those is 90% as anticipated by DOC. Same for serious mental illness. So they think 90% of, and we're hopeful, and that's what we're going to encourage, 90% of the incarcerated individuals will participate in this reentry program for the 45 days prior to release. And that will include, as I said earlier, Medicaid enrollment or re-enrollment. We're going to, make sure that they're up to date on their redeterminations and things like that. So it will include all of that. Next slide. That's what I have. That's my contact information, so please feel free to ask me any questions you have. We're still doing a lot of work on this, and we still have a lot of unanswered questions, like about Medicare duals. CMS wasn't quite sure which direction. They haven't received a question about Medicare duals yet, so I asked them the question last week, so they're gonna get back to us on that type of thing, but lots of questions about different populations and tons more to come. And I presented this at the Community Mental Health Center meeting last week, and I told them I would come back and give them updates. So as I share updates with them, I will make sure I share updates with you if any new developments we come across. So thank you for your time.
Question, Carolyn.
Yeah.
So it looked like for your two columns for people being released with SUD and or SMI, that universe was about 753 out of 991.
Yes.
So let's call it 75%. How are you capturing co-occurring disorders? So are there double counts in those columns?
No, they're one or the other from what Department of Corrections said. Because
who decides?
I don't know if one trumps the other. I'm not sure how they do it, but they can be seen by the doorways, or they can be seen by a community mental health center or their provider of choice. Some people have formed relationships with private practitioners, and we are not limiting that to say you have to go see this provider. It's the freedom of choice thing. So they do assessments. I'm waiting for the tools, the screening tools, and how they actually put all this together. Department of Corrections, because it's been, this is the most we've worked with them in my years here. So, and they've been great and open to sharing. So I will find more detail about that, about how they decide which one, if there is one that trumps the other, which there really shouldn't be.
Well, exactly. Yeah. And that's sort of where I'm going, that we should be able to provide holistic care and not force people to choose a diagnosis that may then, like, oh, you can get it over here faster than you can get it over there. So let's make you SMI today and kind of put your SUD on the back burner. Like, we know the co-occurrence is so strong. We should be looking at the whole person if there's a way to do that.
I'm sure they have a formula. I'm sure they have a process on how they do this. Okay. I will definitely check.
Yeah, it's a good point, because we will, at Center for Life Management, we will treat people who are co-occurring, but at Greater Nashua, who puts themselves out, I think Greater Nashua is literally a part two and has a bigger bench of said services that they deliver. So at least as we move forward, it will help on the engagement of providers in which doorway will be the right doorway for the individuals leaving the facility.
And the intakes are also going to happen. They can happen in person, but the reality of it is, to go into a state prison, there's a lot of checking that needs to happen. So it will most likely be telehealth. And we're talking about DOC is talking about purchasing secure telehealth booths. So it will be secure, safe, confidential. I mean, they can't put people in people's offices to do these intake appointments. So we're really thinking through how we can make this work, where people can get timely services as well as safe for the staff, and not having to utilize additional staff members at the Department of Corrections. So we have a lot of thoughts and a lot of planning that we are doing daily. So, but I will definitely take your question back, because I know they have two screening tools. I'm just not sure how they separate the people after they do the assessments on them in DOC. They have their intake.
Thank you.
Sure.
There's a question and a comment.
Okay.
Rhonda Siegel asked, what type of insurance does the other 15% being released with SUD or SMI have, or do they?
They could have no insurance, or they could have private insurance. I'm not quite sure. We only focused on Medicaid, because that's what this demonstration is for, but we probably could find that out. We know who the inmates are, so we just focus on the Medicaid, since it's a Medicaid demonstration. They could have Medicare too, because Medicare stops when you go in prison.
All right. Any other questions for Carolyn? All right. Seeing none, let's get the latest and greatest on the unwind of continuous coverage.
All right. So I'll be providing some information on enrollment trends that occurred in July. July was actually the last month in which we had someone that was protected at the start of the unwind go through their redetermination process. So we're technically now out of the unwind, which is exciting. But so for September, we just ran our ex parte rates. It continues to remain high. September was a little higher than the last, looks like 6 or 7 months. It was at 85%. And I think the 85% number is actually the highest in the nation right now. And so this is 85% of all redeterminations were passively renewed because we're able to confirm, income or assets through electronic sources. And some of this relies on E14 flexibilities from CMS. And those, although the unwind is over, the CMS flexibilities are in effect through June of next year. So this is our trend in Medicaid enrollment. So you can see over here on the left-hand side is the number as of the start of the public health emergency for COVID-19. And then our most recent numbers as of August 5th, 2024 are on the right-hand side. And the peak here is really when we started the unwind. So you can see a lot of these have stabilized and some of them have ticked up a little bit, like low-income children. There's been a slow increase there. And this is just a snapshot of the redetermination status for the waiver population for Medicaid. So for July, there were 861 financial redeterminations for the waiver population. 779 of them completed redetermination, which means they redetermined, remain open. And there were 5 closures. But you can see down here, the passive, there was 693. So the majority of the people that completed their redetermination were passively or ex parte renewed. And this is just a look at the CFI population. There were 215 up for redetermination in July, 197 completed, 179 of those were ex parte, and there were 18 pending at the end of the month. And some of that pending population is because we're still continuing to allow the additional 60 days after someone's redetermination date, if they're in the CFI population, to provide their outstanding documentation. But for reporting purposes, they show up as pending. And this is the same look for nursing facilities. So there are 280 redeterminations in July, 4 closed, 232 completed, 184 of those were passive. And this is a look at our CMS reporting and closure reasons for July. So you can see for the general population, the renewal rate was 90.3%. So very similar to prior recent months where we're right around 89 to 91%. And then if you look down at the closure reasons, it's income and then failed to read is by far the highest. And this look is March through July for CMS reporting and closure reasons. So this is really a snapshot of what it looked like for the unwind period for redeterminations in the protected and non-protected populations.
Can we pause for a second?
Yep.
And just talk about the orange line?
Yep. So the orange line is the number of individuals that retained their Medicaid, so they redetermined successfully. Total, we had about almost a 70% renewal rate. In the protected population, so these were the individuals that as of the start of the unwind had not done a redetermination in the prior 12 months. 30% of those individuals retained coverage. But in the non-protected, it was up at 83.8%.
And one might reasonably think that the protected population, 70%, by and large at least, no longer met eligibility.
Yep. And you can see, they had a higher rate of closure for income at 32% versus the non-protected at 20%. There is still a large group that failed to read, so they didn't provide their documentation. Just on some information we had available to us, I think there's a good portion of that failed to read group that we're not going to redetermine because of income. But we don't know officially because they didn't provide us, an income statement that says they're over income.
But those are failed to read as opposed to failed to provide verifications.
Right.
Yep.
So I would say anecdotally, I know lots of people who knew, at the expiration of PHE when they were coming up on a redetermination, they knew they were over income. Like, why am I going to do all this paperwork to tell me what I already know? So I think your assumption, the anecdotes support your assumption about, how high that number is, because I wouldn't.
Yeah.
Yeah. And we did do a survey, and this was just for the people that closed over income, but we did the enhanced survey this winter, and that showed that a lot of the people that did close for being over income had found other insurance,
Right.
At least the ones we were able to reach.
Yeah. Yeah, I just wanted to acknowledge it because sometimes it's not as quick for all of us to process the numbers as we move through, and then we go back and do it when we're sitting alone to review the information, and then it's just good to have that discussion, I think, so that we are all on the same page and understanding.
Yeah, no, I agree. Thanks for bringing it up.
The numbers look good. I mean, that's really what I'm trying to get to. Although we do have challenges.
Yes. Everything is not perfect.
No.
And so this slide is just similar to what we've shown in the past, but it's the MEA reporting slide for June. And for this month and going forward, we've started to break it up into people that still remain open in Medicaid and what their MEA result or redetermination outcomes were, and those that are now actually closed in Medicaid. So there were 636 that were due for an MEA. 278 were bridged. We've also started to add in the appealed and not appealed. 342 completed their MEA, 314 met level of care, 20 did not meet level of care, and 8 failed to provide documentation. And then there's a new column here just showing those that are closed under HCPC due to other reasons. So moved to a nursing facility, or we're also tracking people that moved out of state or are deceased.
So I'm looking at those, but maybe I'm wrong and you can straighten me out quickly, please, if I am. But I'm looking at that and kind of going, thanks.
So we do have a process to bridge MEs. I think Christina can probably talk to it a little bit more, to allow more time for individuals to provide documentation or for us to complete the MEA. So that, I think, is why the bridged number is high. And on the failed to provide MEA documentation, when you look under the closed Medicaid, I think this is the first month where we've really seen a really low number there. And for the people that failed to provide, they're in a suspended status to give them additional time, but we're still tracking who falls into that bucket of failed to provide separately.
Okay, so not really a yikes. I can take that back. I'll take that off the table. But can I sidebar for 1 second and say, I think it would be helpful in another meeting. So I'm going back to an earlier agenda. I apologize if it's confusing. A future agenda item, really to talk about the best way for people to be submitting documentation. And it's not just related to this, it's for new applications. I think it's a good time for us to sort of polish that off and talk to people about how they can ensure their information that they're sending up here is getting to where they want it to go.
Yeah.
Thank you.
No problem.
Do you want to speak to bridging?
Or do you have anything you
Yeah.
want to add to that meeting or the bridging conversation?
No, I think we've already covered. Okay. Thank you, Jake.
No problem.
All right. It's the Dave show today. That's what Henry gets for being out of town, I guess.
I like it.
So let's talk about managed care 2.0.
Yes, so after our July MAC meeting, we had our governor and council meeting where amendment 1 to the managed care contract was on the agenda, and it did get approved at GNC, which is great news. So we're going live with MCM 3.0 on September 1st. And from our perspective, this is exciting. There's a couple new models in here. I know we've talked about them at prior meetings, so I won't get too in depth in them, but just the primary care focused model will be going live. The community mental health center minimum fee schedule, directed payment requirements will be going live. We're also bringing in comprehensive medication reviews and the high cost drug pool. We included a link to the approved contracts in the agenda for everyone's review. That's all I have to share on that.
Great, thank you.
Yep.
Okay. So let's pivot to the AT 805 subcommittee.
This is Kara. I can speak to that. As far as I know, we're still waiting for a response from the department, unless I've missed something. I think that's what's still in the works. Is that correct, Brian?
Yeah, that's correct. And we were also looking at whether there should be changes based on the HE 310 to be able to utilize the grievance process that's going to be in place with the adoption of the HE 310.
Okay, so once we get the response edits to our feedback from the department, then the committee can regroup and decide if we're going to meet again, and we'll go from there.
Yes, you'll be getting a new draft of the initial proposal with how the department intends to move forward, as well as a response document documenting that we heard what was said at the subcommittee meetings and our responses.
Okay, thank you, Brian. That's all I have on that.
Okay, thank you. So let's also check in on the HEE 310. I did see the conditional approval request as part of the materials for this morning. Does the subcommittee have any follow-up or comment on the conditional approval request? Hearing none. Does that mean that the subcommittee has concluded its work?
I think we had concluded our work. We were waiting for the forward motion from the department, but Carolyn, I think, is no longer online, and so, but I think it is completed.
Great. Okay. Do we need to go into any of these? Because I think the status is kind of self-explanatory on these 4 at the bottom of the agenda, or are there people that want to speak to it?
I don't think so, unless there's someone from the MCAC that wants to ask questions.
Okay. Seeing none, let's move on to department updates. At the top of the list is adult dental, and Dr. Finney has joined us.
Good morning. I did provide a report that was emailed out to everyone on Friday. We continue to grow the provider network, which is very exciting. We had an increase of 6 providers from last month when I reported to you. And I can say that we're continuing this growth. We have at least another 3 or 4 providers in the pipeline right now who should come on board in the next few weeks. The recruitment endeavors are ongoing. DentaQuest is doing a wonderful job with their provider rep who is out in the field actually meeting with people one-on-one, face-to-face, which I think is very important and seems to be working really well. I do want to make a correction on the claims count and unique members treated. If you are looking at past notes, you will see that last month there was a unique member count of approximately 16,000. And I realized when I got my numbers for this last month that there was something that was out of whack. So basically, we've been seeing a monthly increase in the unique members brought into the program and receiving treatment of somewhere between 500 to 1,000 or 1,200 individuals. So June really should have been 13,956 unique members. July would have been 14,626. And then you see the August 1st number is 15,243 unique members. So I just wanted to be very transparent and make sure that you see that we are gaining significantly every month. There's also now I think, very, very robust schedule for the mobile services. We continue to talk with individuals across the state to make sure that we're getting those services where they're really needed. And that includes, some of our nursing facilities and other facilities. So you will see that this schedule will continue to grow and we will add more locations to it. It takes a bit of time to bring a new site into the schedule and get those schedules set out, a number of months in advance. So I just ask for everyone's patience, but we are still working on this. This is not something that's going to sit like this forever. We continue to make sure that we're adjusting the schedule to really get where we need to be.
Dr. Finney?
Yes.
Not for today, but can we also put this on the future agenda item, maybe next month, that you could talk to us about how you identify those sites?
Okay.
That'd be great.
Will
Thank
do.
you.
So you can see that we've had a total of 93 mobile events. We've served over 1,100 members at those locations. Solvera does a great job of not only maintaining wait lists for each of the sites, but they call and email and text to make sure that folks are reminded of their appointments and given an opportunity to reschedule if need be. So that is working well. We continue to have our same cadence of meetings with Northeast Delta and DentaQuest. I can assure you that at a minimum, I see those folks 4 days out of 5 a week for one reason or another. We have a lot of things going on and everyone is still at the table working very hard to make sure that, we continue to grow and get to where we need to be.
Remind me how many claims was it that I saw that were paid?
Claims for this last month was 44,000.
Yeah, that's great.
That's a lot of claims.
Really great. Nice job.
And that's it for this month.
Keep that.
Yeah.
That's good news.
Thank you.
Oh,
Joan, question?
Oh, Joan, do you have a question or a comment? You're on mute. We still can't hear you, Joan. Maybe do you want to put your comment in the chat? Maybe while Joan figures out her tech, we can pivot to the DDU.
And she just.
Yes, good morning. So we are, I know it doesn't look like it as you look at the numbers, but we are making some progress here. So out of the children's cases, there's a total of 80 children's cases pending. 15 of those were over 90 days. As of this morning, there are only 4 actually over 90 days. So they've made a huge improvement on the timeliness of the children's cases at this point. So that is one area that we're really seeing improvement in. There's currently 870 adult cases pending, with 539 of those being over 90 days. Out of the 870 cases, 507 of those are at the final stage, meaning they're ready to be reviewed by the medical review team, or already in review and in the final stages of that. Of note, there's 69% of the adult, out of the 870, 69% of those individuals currently have Medicaid through another avenue, and 38% for the children. There is still that bottleneck with the contractor, as you can see by the 507 cases. They have picked up over the last several weeks and are averaging about 40 a week back to us. I know it doesn't seem like a lot, but just for July alone, they closed out 182 cases. However, we did receive in 162 cases. I bring this to your attention because you're not seeing these numbers drop down a lot, if any, because it depends on the amount of applications we're coming in, but they are working on it. We're currently in the process of bringing on hopefully another contractor that would start beginning September 1st. That contract is due to go down to GNC on August 30th. So if that is approved, a second contractor would be onboarded September 1st. And we're anticipating we can get these numbers down fairly quickly with 2 of these contractors working on it. That's all I really have. Does anybody have any questions?
Kelly does.
And then Karen too.
Okay.
Thank you,
Sure.
Scott. I appreciate all the effort and the work that goes into doing this, and your communications. They really are helpful, because as I deal with my team in the field, I'm able to provide some clarity and information back to them that reduces, I guess, anxiety for people who are in this queue. But can you repeat or help me to understand how many, and let's just talk about adult cases if that's the way we have to do it. How many adult cases are you able to finalize their disposition in a given week?
In a given week, adult cases alone, right now, it's currently, let me give you last week for an example.
And again, while you're looking that up, my intentions are good. They're always good. And
Okay.
they really are to make sure that I can provide some clarity and manage expectations in the community. It is very helpful.
Okay, perfect. So last week, 36 minus 4. So last week, 22 of those were adult cases and 14 were children's cases that they closed out. The week before, it was 27 were adult cases and 13 were children's cases. It really varies.
Thank you.
Yeah, so like this week, there may be more adult cases closed out than children's cases. So thank you for that.
Thank you.
Karen, did you have a question?
Yeah, I had a couple. Thank you for your time on this, Scott, and for all the information. I guess I have a couple of questions. One is, I'm really glad to see that you're bringing in a new another subcontractor or contractor to work on this. How long do you anticipate it will take that contractor to be like up to speed to be able to help make a dent in this backlog?
So good question. Good question. This particular, we brought this, we had to go through the certain channels, and that's why it takes a while. As you know, in state government, things don't happen overnight. However, we went through the sole source channel for the contract, and we're bringing on our previous contractor, Equus. So they already know our process. They already know the procedures. So they've basically said they can hit the ground running on day one. So basically onboarding the first week of September. Of course, this is all depends on the approval at GNC, but assuming that everything goes on August 30th, September 1st, they would start. Onboarding would be the first week in September, and then we would expect, 30 to 40 cases per week from them the second week in September.
And then as far as, but all of this is going in an environment where you're continually getting new applications, correct?
Yeah. Yep.
So I guess what I'm also wondering is it possible at all for there to be sort of an all hands on deck operation where even the department gets involved in helping to process some of these applications where people have been waiting for, more than 90 days for a response?
So that's a great question. Unfortunately, the department no longer has a medical review team themselves. We have taken steps. We are bringing on, I have 2 positions that were just approved 2 weeks ago and are posted for a medical reviewer, one full-time and one part-time to bring on. We do not have the staff in-house to do the entire process ourselves. Therefore, it has to go outsourced at this point. We have worked tirelessly with some of the other units, BDS, and the children's behavioral health units to obtain additional information, guide them in some information that's helpful to get to us right off the bat, to try and get some of these processed. But it's not something that the department at this time can any longer do by itself. We need the outside contractors.
Yeah.
With that being said, we're looking at, an average of anywhere from 20 to 50 cases, new cases per week coming in. And so if we're looking at, each contractor doing approximately 40, that's 80 cases a week going out. That's why I'm saying with those numbers, if that's what we can hit, we would expect this backlog to quickly be under control.
So I'm not that fast at doing math. So 80 cases get decided a week, and that includes the new cases that are coming in. So I 536 divided by 80. So like you're looking at a few months. Like how long do you think it's going to take to clear up this backlog and get on
Well,
track?
it depends what you mean by backlog, because there's always going to be cases that are ready. Are you talking over the cases that are, say,
Like
over 90 days or?
Exactly, over 90
Yeah.
days. So where you've got 539 that are over 90 days, but they're going to be processing those together with the new ones.
Right.
How long is it going to take to get it down so that the department is fully in compliance with federal law around the determinations?
I would
timelines?
I would say 3 months to be on the safe side. I would say 3 months.
Okay. And then I'm sorry, I really appreciate your taking all my questions. I know I'm asking quite a few.
I wish I could give you exact answers, but yeah.
I know, but you're doing the best you can. I get it. So one matter that's in the report that's been sort of a concern of mine going on is this. I understand that that a percentage of people have insurance through like Granite Advantage. But I am concerned about like what the communication is exactly about asking people if they still want to pursue APTD, because for some of those folks, the cash assistance really makes a difference.
Mhm.
Are there written materials that go out to folks who are in this position where they're awaiting the determination for APTD, but also have Granite Advantage? And if so, could you share them?
So there's no particular communication that goes out for somebody that has Granted Advantage and is applying for APTD from us. We do notify them once we at DDU receive their application. We notify them that then, and then we notify them if there's information that's missing. But there's nothing particular that goes out that says, hey, are you still looking for this? You know, we do make contact in the beginning of the application. Sometimes people do decide, you know, as we're working through the application, they decide not to follow through. They withdraw their applications, things like that. There's nothing specific to the cash. We do have a dedicated number for us that clients are given if they want to check the status of their case.
Yeah, I'm just concerned because the bullet says, you know, inquire if client is open, Granite Advantage, and if so, do they still wish to pursue APTD? And that raises concerns for me because I don't think it's. I think people need this cash. I mean, we talked about, like, you know, there's inflation and cost of living, and we're talking about people who are pretty poor. So I would hate to think that the department is discouraging people to pursue these applications when, you know, that bit of money might be really helpful to them.
Right. No, we're not discouraging. I think that the block that you're reading on was something that our partners, our community health partners, things like that, prior to them applying, really look at it. Remember, this is a permanent disability program. We do get a lot of applications because people will apply for cash assistance because they're saying, well, I'm going to be out of work for a year. This is a permanent disability program that you must be disabled for a period of 48 months. So it's not a temporary cash assistance. It really is permanently and totally disabled. But that block was put in there that others can inquire to them if they have Granted Advantage, do they still want to pursue the Medicaid portion? And that's really what I'm reporting up at the top, that 69% of these people that are applying for Medicaid are already open for Medicaid via another program. Now, we don't want to discourage them from applying for APTD because some of them may be on Social Security and next year they're going to have Medicare, so they wouldn't be eligible for, say, Granted Advantage, things like that. But that's just to give you some information and how it can assist us with this timeliness. Because if there's truly people out there that only applied because they only wanted Medicaid and they only wanted it while they were unemployed, let's say, and that's no longer the case, well, if we can weed those out, and with you folks and everybody helping us out, if we find out those people no longer need that, we can move on to some of the needier people who actually really need it. So that's why that was put in there, that block.
Okay. Thank you for your time.
You're welcome.
Holly, you have your hand up.
Yes, thank you. And thank you, Scott, for all this information. We just recently learned that what also falls into this category is kiddos waiting for what used to be Katie Beckett. And so I'm just curious if the department tracks how many of these kids are currently in emergency rooms waiting for Medicaid, because we know that there are certain services that commercial insurance will not pay for, that Medicaid does pay for, that will move these kids out of emergency rooms. And, you know, how that factors into this, because we know that somebody waited for 9 months. So like, I get that it's 90 plus days, but a lot of these cases are not 93 days, 94 days. They could be 180 days. And they all fit into that one category. So I didn't know if the department has a sense of how many of these kids are waiting for services not paid for by commercial insurance, and without Medicaid, they are suffering.
So just to clarify at this point, as of the end of July, there were 15 children's cases that were over 90 days. So formerly known as Katie Beckett, there were 15 cases over 90 days. At this point, at this very moment, there are only 4 cases that are over 90 days. 3 out of the 4 are in the final stages. One is still being worked up due to incomplete applications and releases and trouble getting things from the provider. So it's not hundreds of cases at this point. I understand at one point there was more. But to get into your question a little bit more, my unit does not track that. I would have to defer elsewhere through Medicaid if they track that type of information.
Okay, thank you, Scott. I appreciate it.
You're welcome.
Kelly, follow up?
A couple of points. Holly, I think Care Traffic Control out of New Hampshire Hospital will have some insight on that for you. Certainly, they used to track all of the insurance in specific matrix and could pull out at least the children. It may not say they're pending from Medicaid or Katie Beckett, but they certainly have intel and keep a line of visibility on that. And then just a question. Well, I'll make it a comment, so it's not a question and you don't have to respond. But I would wonder if the state would have an appetite at any point for revisiting because we're only one of 8 states where people who go on SSI don't get Medicaid. All the other states of the country do it. The state, for legislative reasons and budget reasons, has always chosen not to. But you never know if things would change, and just something to think about. And I know that people or legislators might, like some legislators would say, well, no, we don't want them to get eligible quicker because that's going to cost us more money. But that's not true because they'll be retro back to the time that they were approved. So just a thought to put out there. And really, I know it's not an agenda item and I'm not asking for a comment. I'm just asking for future thought process. Thank you, Scott.
Thank you.
Okay, how about we move on to the HICPIC spending plan?
So we linked the most recently approved spending plan in the agenda. The department continues to work on the initiatives outlined in it. I don't have much more of an update on that, but I can provide a couple updates on the waivers. We just want to keep moving forward. Great. So for the personal care state plan amendment, the 1915J, this continues to remain in place. There are no changes for now. The 1915I supportive housing state plan amendment was submitted to CMS. It's currently pending and we're awaiting CMS approval. We did have to submit an updated SPA, and that's the one that's pending CMS approval. And the update was to align billing codes with rate methodology. It was a request CMS made of the state, but it doesn't ultimately impact what the providers would be paid. Under the 1915B waiver renewal, just a clarifying comment in the parentheticals, it says justice involved youth inside SMI SED. The 1915B is for our managed care enrollment, but it was recently amended because justice involved youth and SUD and SMI are going to be enrolled into managed care as part of the community reentry and the youth reentry. We actually got an email from CMS this morning that that amendment has been approved. So that's some late breaking news. And I'll pause there to see if there's any questions on the waivers.
Seeing no questions.
Great. On the Medicaid to Schools grant, so we did receive the federal grant from CMS, and so this provides the state, I think, originally we thought it was going to be $2 million, but it's a little more than that because there were only 18 states selected, not 20. So it's going to be around $2.25 million, and this will help support New Hampshire and the other grantee states of implementing the new claiming methodology for Medicaid school-based services.
It was originally 2.5, and that's gonna be like 2.75.
Oh, okay. Yeah, so even higher. Thank you.
Okay.
And on the mobile crisis spa, it's been submitted to CMS and we are just awaiting for CMS approval of that spa.
Okay. So we have the consent agenda. I didn't receive any requests to take any of these items off of the consent agenda. Kristen is shaking her head. She did not either. Though it looks like a long list, they're usually, a lot of these are just a line or two and maybe one edit, you know, because we have a word that we like better now. Instead of means, we're saying namely. So unless anybody objects, I think we can take a motion to approve the items on the consent agenda. Okay, I will move to approve the items on the consent agenda. Do I have a second?
Second.
Thank you. Who was that? Did you get it?
Yeah, I just didn't.
Okay, okay. All in favor?
Aye.
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 Any opposed?
Aye.
Okay, motion carries. I know we have the legislative update on here. I know that the attachment went out. We don't have Rob. Are there questions or concerns about anything on there that maybe those who are here can answer? If not, kind of a slow time of year, thankfully. Go ahead, Karen.
Lisa. So, well, one thing I noticed that Rhonda Siegel has a question in the chat about a prior agenda item. So,
Thank
and then
you.
okay. And then I do have, as far as the bill tracking, I think the governor signed 1168, which is the committee to study the impact of the housing crisis on people with disabilities, and that there's actually, well, there was a meeting scheduled. It looks like it's been postponed, but just wanted to give that update.
Thanks. Yeah, I'm just on the legislative website now. It looks like it was signed on July 12th.
Great.
So Rhonda's question, oh.
Just so Rhonda's question was, is Medicaid to schools still for students on IEPs only? I think is the question, and the answer is no. We will also cover services not on an IEP, so 504 or other care plan, as long as the service is provided by a qualified provider and, you know, appropriate to the setting. Medicaid will cover the service.
Okay. Despite the late start, we look like we are ahead of schedule. Hallelujah. We covered a lot of ground today too.
Oh, Rhonda just asked,
Oh, more questions?
does the student need to be on an IEP?
No. Student does not need to be on an IEP.
Hey, do we have a motion to adjourn?
So moved.
Do we have a second?
Second.
All in favor?
Aye.
Aye.
Any opposed?
Have a
Motion
great
carries.
day,
Everyone.
Thanks so much.
Thanks all.
Bye.
Good job, Kelly. So I'm just gonna start getting here extra early.
We'll get here.